Imagine a world where medical technology advances so rapidly that we can encounter unexpected problems, like diagnosing too much of a condition. This is exactly what is happening with thyroid cancer in the United States. Over the last 3 decades, we have seen a rise in the number of patients diagnosed with thyroid cancer, but we don't see a change in the mortality of thyroid cancer. Why is this happening? Well, it's because we are finding small, sometimes indolent, thyroid cancer lesions in patients who don't have a symptom. And the problem is that once we find them, they usually are treated similar to how we treat patients with more aggressive thyroid cancers. So we have an overdiagnosis of thyroid cancers that lead to the overtreatment of thyroid cancer. So what is driving that trend? The answer lies in the use of thyroid ultrasound. Thyroid ultrasound is like a double-edged sword. On one hand, it helps us diagnose big problematic thyroid nodules or big thyroid cancers. But on the other hand, it really drives the the overdiagnosis of thyroid cancer. So what is the catch here? Well, many ultrasounds are actually not needed or ordered inappropriately. So imagine now that we can actually differentiate and classify which of these ultrasounds are really needed from the ones that we don't actually need it. That classification and identification of these ultrasounds will certainly help in avoiding their use and the overdiagnosis of thyroid cancer. I'm JP Brito, an endocrinologist and the Innovation Chair of the Division of Endocrinology at Mayo Clinic and the Principal Investigator of the Care Unit at Mayo Clinic. Today, I will be summarizing the results of a paper titled Ultrasound Appropriateness Identification Through Natural Language Processing of Electronic Health Records, soon to be published in Mayo Clinic Proceedings, Digital Health. In this study, we utilize natural language processing to analyze information from electronic health records, including clinical notes, diagnosis, and ultrasound reports. We were able to classify the appropriateness of each test and even infer the actual reasons behind their use. That approach helped us determine whether an ultrasound was ordered for valid reasons. For instance, we found that the majority were appropriate, but in some instances, the ultrasound was not ordered appropriately. Those instances are caused by a screening of thyroid cancer, which is not an evidence-based reason, or by patient requests that they just wanted to have that done. This tool that we developed at Mayo Clinic is using mostly Mayo Clinic data and really requires validation outside Mayo Clinic, which is actually being conducted right now in University of Florida. Once it's validated, this tool will be deployed in different healthcare systems and will be providing for the first time a clear picture of the frequency of inappropriate thyroid ultrasound and the reasons behind their orders. With this information, we will aim to develop interventions that actually decrease the use. This study also serves as a proof of principle for the use of natural language processing and artificial intelligence as tools to support research in addressing what is called low-value care in medicine. Thank you for your time. I will encourage you to read our article online.